It's nice to see Dr. Hong. Dr. Hong, Dr. O, nice to see you. I wish I could see you guys in person. I just wanted to comment on the use of ECMO as a bridge to transplant. Um, the French system used to use it, but they had a very high mortality post-transplant. So they've changed their system so they don't use it. ECMO is still the highest priority in our system, but very few people use ECMO because the post-transplant outcomes are so poor. So I'm going to talk about, hang on, I'm going to talk about, I have no financial disclosures. So the management of transplant is a balancing act between over immunosuppression resulting in cancer, toxicity, infections, under immunosuppression resulting in rejection. And the major causes of death post-transplant include cardiac allograft vasculopathy and graft failure and malignancy. Early on, it's rejection and infection. So our goal is to be able to mitigate all of these. And this is from a paper by Phil Halloran in the New England Journal of Medicine, 2004. It's an oldie but goodie. It goes through all of the pathways of rejection and tells you where the various drugs work that we use. Immunosuppression is a very good reference. This has been the standard for decades for making the diagnosis of rejection. This is endomyocardial biopsy, and we obtain pieces of tissue. These are the grades. These are mild. These are now called 1R. So some lymphocytic infiltration, but no myocyte necrosis. And this is a 2R, and these are 3R, extensive lymphocytic infiltration with myocyte necrosis, and in this form, inflammatory infiltrates. So the search for an alternative to biopsy has been going on for many decades. The ideal rejection screening test would be highly sensitive for rejection and adverse outcomes. A negative test would strongly be associated with good prognosis. Positive test indicates need for treatment or further workup, should be non-invasive, easy to do on an outpatient basis, and have decreased costs. So let's get back for a second. So there are a lot of cells in the periphery that undergo gene changes in response to rejection. And these are the various gene expression profiling trials that have been done. And I'll discuss these briefly. We've seen this before. So the very first study was the CARGO study, an observational study, cardiac allograft rejection gene observation study done in 8 transplant centers with over 600 patients, close to 5,000 encounters, a 3-phase study. Initially, the hypothesis was gene expression profiling of peripheral blood can discriminate ISHLT grade 0 from moderate 2R, 3A rejection, and there was prospective validation. So initially, there was microarray to identify genes whose expression either changed either up or down at the time of a 2R rejection compared to a 0. So this shows the genes with upregulation, downregulation at the time of a 2R compared to a 0. And then once that was done, a group of patients were studied with the algorithm that was developed, including 11 genes and 9 housekeeping genes as internal controls, to validate that there was a difference with blood obtained from somebody who had a 2R rejection versus somebody who had a 0. And then there was a prospective validation study of all comers in these centers. These are the genes that are involved, many different pathways, a number of them steroid responsive, which means you can't use this test in the first 2 months until the dose of steroids becomes less than 20 milligrams a day. Otherwise, you'll depress the score. And the result was that molecular diagnostic testing significantly distinguished grade 3A with 2R from grade 0. So low scores mean a low risk of grade 2R rejection by biopsy with negative predictive value of over 99%, which means patients who have scores that are lower than the threshold do not need to be biopsied. Another thing that was discovered in this study was that there was tremendous subjectivity in making the diagnosis of 2R rejections. So there was a core of pathology experts who looked at all the biopsies and downgraded 62%, indicating that people have been overcalling rejections, which is kind of a scary thing because it means that we've been using higher dose immunosuppression than we should. This ultimately became the AlloMap, and more than 50% of centers in the United States use them. And during the pandemic, as you'll see, they were especially important. We were among the first to use this when I was at Hahnemann, Drexel Hahnemann, in March 2005. So we would examine patients, get echoes, and if the score was higher than threshold, we'd do a biopsy. Lower than threshold, we would not do a biopsy. If there was clinical evidence of rejection, we would do a biopsy. And these are all the studies that have happened from 2007 to 2016. There was a randomized study, the IMAGE study, of management using gene expression profiling versus management using biopsy. And it was endpoint driven, so changes in cardiac function, rejections. This is the randomization schema. And here's one of the problems with the study. Most of the patients were studied beyond the first year post-transplant, which is not when rejection occurs. It occurs in the first 6 months. So that was a problem. There was no difference in terms of survival between gene expression profiling and biopsy-guided patients, no difference in primary endpoint. So another study was done at Cedars-Sinai, a single-center study, looking at patients from month 2 to month 6, when rejection really does occur. Otherwise, it was very similar to the IMAGE study. This is the E-IMAGE study, E meaning early. They also looked at cardiac allograft vasculopathy by APCIS, and they looked at the ability to wean steroids using the gene expression profiling test. This is the randomization schema, small study. These are the clinical events similar to the IMAGE study. And so these are the thresholds. So greater than 30, people get biopsied, less than 30, they don't. And then gene expression profiling was obtained. There was no significant difference in endpoints, no difference in primary composite endpoints, and there was a very low positive predictive value. So if you had an elevated gene expression profiling score, you still were not very likely to have a rejection by biopsy, whereas there was a very high negative predictive value. If you have a score below threshold, it's highly unlikely you're going to have a rejection. And they were able to successfully wean corticosteroids using gene expression profiling, as successful in the myocardial biopsy. And there was no difference in IVUS parameters. And it's always good when a clinical trial can be reproduced. So the Cargo 2 study was similar to the Cargo 1 study, except it was overwhelmingly in Europe. And what they found was that there was a very high negative predictive value of and a limited positive predictive value, as in the original Cargo study. And they also found that about 60% of biopsies greater than 2R were downgraded by the pathologist. So once again, we've been overcalling biopsies for years, and that's of concern. So the summary, discouragingly, ISHLT grading is at least objective when trying to fulfill one of its main purposes, detection of severe acute cellular rejection, and most objective when trying to prove negative results, absence of ACR, the goal for which it is unsuited because of the possibility of damaged tissue being missed at biopsy. So endomyocardial biopsy is a flawed gold standard. As a result of the results from the IMAGE study, the recommendation for using the AlloMap is Class 2A, level of evidence B. It's now level of evidence A because there are several studies. And another interesting finding from the IMAGE study was that there is a population that is immunoprivileged, which means they're less likely to develop rejection. So of the patients who had scores below threshold, though those in the lowest quartile were compared to those in the 3 other quartiles. And what was found was that in people in the lowest quartile in terms of scores were much less likely to have adverse events, much less likely to be treated with steroids, and much treated for rejection, and much less likely to have have any of the composite endpoints. And curiously, they were more likely to be donor and recipient negative for CMV. We don't know exactly what that means, but so the AlloMap can identify people who really are unlikely to develop rejection, and so immunosuppression can be weaned in them. And there have been a number of centers that have used AlloMap to wean immunosuppression. This is from the Mayo Clinic, Scottsdale. They were able to wean steroids completely off and also wean tacrolimus, and we observed that as well. So another test that's been developed is the donor-derived cell-free DNA, which is a reflection of injury to the allograft. So when the allograft is injured, it releases DNA, cell-free DNA, which can be distinguished from cell-free DNA released from recipient tissues. And so if that percentage goes up, that indicates damage to the allograft. And this test is being used in cancer diagnostics. It's what's called a liquid biopsy, and it's being used prenatally to diagnose trisomy 21. And here's some of the studies. And so we see here the pattern that if there's rejection, percentage of donor-derived cell-free DNA goes up. Let me look at this. So this is one study from Stanford, which looked at patients' response to treatment for rejections or for elevated donor-derived cell-free DNA. Here's an example. 3B rejection goes up with a rejection. And early on, within the first 2 weeks, there is an elevated donor-derived cell-free DNA level, which is a reflection of ischemia reperfusion as a result of the transplant procedure. So here's the surveillance biopsy. Prior to a rejection, there's an elevation. Treatment with rejection reduces the donor-derived cell-free DNA levels. This is quiescent versus rejection. There is a fair amount of overlap. And any treated rejections also have elevated donor-derived cell-free DNA. And this test can actually predict the development of rejection within 1 month post-transplant, within one month before rejection. And here are examples. So rejection treated comes down here, comes down. And this just shows acute cellular rejection, more copies of donor-derived DNA released from the damaged allograft. And again, other examples with 2R rejections. And also, this is seen with antibody-mediated rejection. So here's an example. Elevation with antibody-mediated rejection. It's treated, it comes down. And more examples. And there is something called the SHORE registry, which is looking at donor-derived cell-free DNAs from center in the U.S. to see if this can predict cardiac allograft vasculopathy. There will be a prospective study, the DETECT study, which will look at whether elevated donor-derived cell-free DNA predicts the development of cardiac allograft vasculopathy, which can also cause allograft injury. So this may be a long-term way of monitoring allograft health. And the other thing is it can be used within 2 weeks post-transplant, as opposed to the AlloMap, which can be used only beginning 2 months post-transplant. So a lot of centers in the U.S. have evolved to just doing 2 to 6 biopsies in the first year and much less afterward. And those 2 biopsies are before donor-derived cell-free DNA can be used, and those are surveillance biopsies. Of course, if somebody has symptoms or graft dysfunction, then you would do a biopsy for cause. And this is the SHORE study I mentioned. So the goal is to see whether donor-derived cell-free DNA can identify patients with cardiac allograft vasculopathy or at risk of poor outcomes. And this is, again, what I showed you, elevations with 2R rejection. So let me tell you how we and other places used these tests. So spring 2020, a new highly contagious virus with respiratory spread and mortality higher than seasonal flu is upon the land. Hospitals and ICUs are filling up with the sick. The virus is spread by asymptomatic infected individuals. As this is a novel virus, there is yet no vaccine or no antiviral agents that work. No hydroxychloroquine and bleach don't work. This sounds like science fiction, but this is the early days of the COVID pandemic. And in immunosuppressed patients, the sequelae of viral infections are more severe with those with them than with others. And so the goal is to try to minimize the exposure of immunosuppressed patients to the virus, which means minimizing their exposure to crowded settings, places where they could be exposed to virus like hospital corridors, waiting rooms, cath labs, clinical labs, recovery rooms. And so what was done was to send out teams to patients' homes to draw bloods, including the AlloMap and its donor-derived cell-free DNA. Of course, if they're elevated, those people would have to come in and get biopsied. But we were able to significantly reduce the number of biopsies and therefore reduce infection in our patients. And this kind of shows why we're doing this. This is Hershey, and our patients live all over the place. They would get their blood sampled. If they needed biopsies, they'd come in, but if they didn't, they wouldn't. And also, the reason why this was advantageous is that this region was relatively under-vaccinated, so there was a lot of virus. And these are some of our experiences. And actually, CareDx, who makes the AlloMap, set up a similar commercially available program called RemoTrack, which they applied around the country. So we prevented 25 endomyocardial biopsies, 32 visits to the lab were prevented, and none of the patients transplanted in 2020 or 2021 developed COVID-19. So donor-derived cell-free DNA obtained remotely can provide guidance as to which patients have evidence of myocardial damage and need further evaluation. Remote testing, as with telemedicine, may become part of routine care, and for us it has, because our patients live at a distance. And advantages would be convenience and minimizing exposure to infectious agents. And pandemics provide inspiration for innovation and creativity. So what's in the future? MicroRNAs are one of the things that's in the future. These are being studied. There are many microRNAs that are involved in post-transcriptional expression of genes. And so the question is, which of these are involved in the expression of genes involved in rejection? And here are a few intragraft microRNAs, renal transplant patients. These are some of the ones that are regulated in the setting of acute rejection. So there are ways to measure this, what's called a lab on a chip. And there are, so right now the efforts are being made to identify which microRNAs would be helpful in predicting rejection. Here's some. T-cell mediated rejection, antibody mediated rejection. So these are some of the microRNAs that are changed as a result of rejection. Some more here. Inflammation, fibrosis, apoptosis. So they even correlate with specific pathologic functions. So this is a study from the group in Paris, intragraft and peripheral plasma cells from 60 heart transplant recipients, each patient a tissue biopsy using histologic evaluation, and 14 microRNAs were identified that are associated with rejection. Here are some of the ones here. And another interesting study, involves biopsy, is the InterHeart study led by Phil Halloran in Alberta. And what they do is they obtain biopsies and they look at intragraft changes in gene expression. And so they can identify patterns that indicate harm and poor prognosis, but nobody knows at this point what to do with that. I guess the only thing that we would do is not wean immunosuppression. But it is interesting in terms of identifying changes in gene expression and pathogenesis of rejection, but its clinical implications are not clear. So current approach to immunosuppression is reactive. We just treat rejections when we find it. Otherwise, we reduce drugs if there's no evidence of rejection. And these are the modalities that we have: endomyocardial biopsy, gene expression profiling, donor-specific antibodies, and future modalities would include cell-free DNA and some other assays that I mentioned. So one of the new things is exosomes. And let me just, And this was identified by this individual, a cardiac surgeon who used to be at University of Pennsylvania. Now he's at Yale. And so he looked at animal studies looking at rejection in rat transplants. And exosomes express major histocompatibility complex proteins, and they are elevated in rejections. And he also looked at blood samples from patients who had rejections. Turns out that some of these are elevated as well. So transplant tissues release a stable and detectable donor-specific exosome. Donor-specific signals can be tracked, and islet-specific, depending upon the organ, they can be cell-specific, islet-specific, heart-specific. MicroRNAs can also be added to this. So future studies will be looking at the effects of immunosuppression on acute cellular rejection. Does treatment of acute rejection reverse donor exosome profiles? And there'll be more clinical studies. So I'd like to thank you for inviting me. Kamsahamnida. I just want to add one more thing. In the US now, we have significantly reduced the number of biopsies, mainly using donor-derived cell-free DNA, as I mentioned. At our center, we do 6 biopsies in the first year, surveillance biopsies. Of course, we do biopsies for clinical reasons, but otherwise we do 6 surveillance biopsies, but could cut that down to 2. The reason why we do 6 is we're in an NIH trial looking at the effect of tocilizumab in preventing antibody-mediated rejection, and so they require a few additional biopsies, but I can see us doing 2 a year in the very near future. So thank you very much. I wish I were there with you, and I'm looking forward to hearing Soo-Young Lee's talk. I hope I'll be able to come to Korea in the next year and visit Busan. So thank you very much. Kamsahamnida.